Hello everyone, welcome to series of lectures of pathology, and today we are going to discuss about a cardiovascular disorder. In fact, it's a congenital cardiovascular disorder, and in congenital disorders of heart we have our topic as ASD, also known as atrial septal defect. Now, how do we introduce ASD? It is a acyanotic congenital heart disease which is characterized by defect in the interatrial septum. So we all know that the heart is divided in four chambers. The upper two are known as the atrium and the lower two are known as the ventricles. The upper two atriums do have a septum between them which separates them, and they don't allow mixing of blood in both these chambers. So what we have here is that there is a defect in this septum. So obviously the severity of the defect will depend on size of the opening of the defect, also size of the shunt, that is how much area has been covered, and associated anomalies that will come across due to this defect in the septum. So there would be a wide variety of symptoms appearing. Now, to understand what ASD is like, or how does the ASD develops, or if one says that how is what is the etiology for ASD. So we need to understand that why has this defect been brought on. So to understand that, we need to understand the embryology of heart, or how does the heart develops during the embryonic life. And if we understand how does the septum between the two atrias is developed, so any defect in the development of the septum will result into presence of a septal defect, that is atrial septal defect. So as you can see on the left hand side that we have the development of heart from cardiogenic area, it's very much pretty much undefined, but as the time passes, so we get endocrinal tubes, and the fusion of them will form a heart tube, which further leads into truncus arteriosus, bulbus cordus, primitive ventricle, and primitive atrium, which further differentiates and forms the complete heart. But in that heart, there is a development of the septum. So what happens is there is a structure known as septum primum, which arises from both the upper and the dorsal endocardial cushion. Due to development of this septum primum, what we get is the foramen primum. It is an opening which is primarily positioned. Then appears the septum primum, and apart from septum primum, we have two openings here, that is known as foramen primum and foramen secundum. Now there is a development of secundum septum from along the side of septum primum. So what we have is we have septum primum, we have septum secundum, we have septum primum, foramen primum and foramen secundum. Now this septum secundum further elongates, and it gives rise to a single opening which is known as foramen oval. Further, this foramen oval will close, and the septum primum which came earlier will degenerate, and this foramen oval usually acts as a valve. So this valve will actually allow the blood flow in the fetal circulation from right side of the heart to the left side. So if we understand what is fetal circulation, we all know that the lungs are not active in fetus. So we need that oxygenated blood coming from the whole body. It's actually not from the whole body, it's coming from the umbilical artery. So what happens is that it carries the blood directly to the left side so that it can move on to the other part of the body. So this is the development of the septum. So any defect in this development may lead to atrial septal defect. Now, if we want to consider about its incidences, it usually constitutes around 8 to 10% of congenital heart defects in children. There is around 56 per 1 lakh live births. Recent estimations are quite high, and male to female ratio is around 3 is to 1. Also, actual etiology of this congenital is still unknown, but some factors might play an important role, like genetic factor, environmental factors. So let us look into the genetics. So what happens? The genetic basis of ASD not completely understood, although the majority of the cases there is a sporadic lesion. Yet some home box gene defect have been found to explain some of the well-known familial cases of ASD, such as NKX2 chromosome 5. Other genetic syndrome with skeletal abnormalities of Oram syndrome, which accused by mutation in the transcription factor TBX5, essential in development of both heart and upper limb. Also, ASD can be a part of many other syndromes like Down syndrome and Noonan syndrome. So we understand from this, although we don't have an actual etiology related to ASD, but we can associate it with various disorders or various syndromes or congenital defects arising in the body. So the ASD is usually associated with other symptoms also. Now to understand the hemodynamics. So what has happened? That there was an opening initially present in the septum, which was meant for transportation of blood from right side to left side, because as the lungs were not active, or we can say the pulmonary circulation was not active, so we had just had a bypass. But as soon as the child takes birth, immediately within few hours of birth, this septum will close. But if this septum remains open, that defect is what we call as ASD. Now to understand the hemodynamics of what happens if this opening is still intact. So we see desaturated blood enters the right atrium from the vena cava at a volume of 3 liters per minute, 2 meters per. So approximately per minute we have 3 liters of blood that enters into the right atrium from the vena cava and mixes with additional 3 liter of fully saturated blood shunting from left to right side. So if this there is an opening between both the atrium, so whatever blood which is coming on the left side will also travel to the right side, which will result in increase in the oxygen saturation of right atrium. That means the blood which was supposed to be deoxygenated in the right atrium, now extra blood is coming to the right side, which is oxygenated. So it will the overall saturation level of that blood will increase. So now the right side will have 6 liters of blood. So this is not one stroke volume. We are talking about the overall scenario in a minute. In 1 minute, we'll have approximately the right side will tackle 6 liters of blood, and that will travel to the tricuspid valve and cause mid-diastolic flow rumble. So as there is extra amount of blood there, so mid-diastolic flow rumble means as the atrium will um, atrium will be filled with extra amount of blood. So as the ventricles will relax, the right ventricle will relax and the blood coming from the right atrium will fall into right ventricle. But as there is an extra amount of blood in the right atrium, it will keep flowing. So, in the meanwhile, when this is supposed to get completely filled, but still there is running of blood from the tricuspid vein, which causes a flow rumble. So, and also oxygen saturation might be slightly higher on the right side. Again, due to this 6 liter of blood has to flow across the right ventricle tract and cause systolic ejection flow murmur. So again, if there is extra amount of blood on the right ventricle, that will cause an ejection flow murmur into the pulmonary artery. Now this 6 liter returns to the left atrium, with which 3 liters would be shunted to again the right side, and less amount, that is rest of the 3 liters would be ejected out from the mitral valve. From the standard pathophysiology, and there is a right to left shunt. Left, sorry, not right to left, it's a left to right shunt. What will happen, that is the blood is actually moving from left side to right side, and it's quite understood that why is the blood flowing from left to right, because the musculature and pressure of blood on the left side of the heart is comparatively greater as compared to the right. So there's always a movement of fluid from high pressure to low pressure. Again, there is an increased pulmonary blood flow. As I said, blood is flowing from left to right, and right side is associated with pulmonary circulation. So, extra amount of blood coming to the right atrium. That blood goes into the right ventricle, and that will further go into the pulmonary artery. And as we all know, pulmonary artery supplies the lungs. So, there is increased pulmonary blood flow, which will cause it endothelial dysfunction and vasculature remodeling, which in turn will increase the pulmonary venous return, and it will invert the shunt, that is from right to left, and that condition is what we call as Eisenmenger syndrome. Now let us discuss about the types. Now the terminology that we are going to use in describing the types of ASD, they are all related to the developmental structures that we have seen in the embryonic life. So if it's due to defective ostium secundum, if it's due to defective development of ostium primum, if it's due to sinus venosus or coronary sinus septal defect. So the most common one is ostium secundum, which stands at around making 75 to 85% of cases. So the most common type of uh, ASD is ostium secundum. The defect is in the region of fossa operis. There may be a single or multiple opening and may be associated with partial anomalies, venous return, most commonly of right side. Now, these diagrams are actually telling you about how the different developmental structures or might develop and form ASD. The first diagram A shows the normal development where both septum primum and septum secundum do grow, and eventually they will close in near future. Whereas in second and third, there is a defect in the ostium secundum. And as you can see, my ostium secundum has not developed completely. Whereas in diagram D and E, you can see there is a failure of development of septum secundum again. And in diagram F, common atrium, both the atrium do not have any differentiation or any wall in between them. Second type is Ostium Primum, situated in the lower portion of atrial septum and overlies the mitral and tricuspid valve. So the location differs from Ostium secundum to primum, where the secundum was located in the fossa ovalis, whereas the primum is situated in the lower portion of atrial septum and overlies the mitral and tricuspid valve. Sinus venosus, which is one of the least common type, and it's situated in the upper part of atrial septum in close relation to entry of the superior vena cava. Now you can see um, how the differences or how the appearance is different. We'll discuss the concluding portion in the second part.